Dhami and Abhinav and the entire team of your hospital for having us here. Uh, Nimrita has been calling since really long time and it was due for a long time and I had promised that I'd come, but trust me, I'm enjoying every moment I'm here sitting, the academic part of it and of everything, and I really am grateful to you and for having us here. Thank you. So I'm going to talk about cardinal pointers. Why would I refuse a laser vision correction? And trust me, we should know when to say no to these laser vision correction patients or the LASIK patient. First and foremost, over-demanding patients. Sometimes we actually offer them moon and we tell them that everything will be fine, and without explaining to them anything. And post-operatively we realize that patients are actually not satisfied with the outcome. Hence, there is a golden rule which I follow: no counseling, no surgery. If I am not counseled, I am not going to operate. If I have to operate, somebody else is counseling, I am going to talk to the patient again. I make sure that they understand what's going on, they understand risk and complication, but still we can be smart enough to convince them it's not always that you have to hide everything. In fact, you can counsel them. Most importantly, I can say that after my counseling, my conversion rate is more than 95%. I would be happy if the patient goes and seeks second opinion, because I know that nobody would be able to counsel them better than I would have counseled. That's the reason counseling is something which I would keep in my hand when it's talking about laser vision correction patient. The thing which we want to rule out before jumping over for any weakening procedure of the cornea is corneal ectasia. So we know yesterday we discussed about how to diagnose keratoconus on the topography and pentacam. So keratoconus is something which is the obvious thing in front of us. Sometimes things like pellucid marginal degeneration, which can just give you against the rule astigmatism, need to be looked for. Pellucid marginal degeneration is more of a clinical diagnosis, but anybody who has against the rule astigmatism, unless proved otherwise, have pellucid marginal degeneration. So look for it when you see them on slit lamp, where you see the peripheral thinning, and just before that, ectasia, as you can see from the picture here. Sometimes it may not be as obvious as you can see here. Placido-based topographer, rest everything is fine. Pachymetry normal with the ultrasound pachymeter done. But on your tomographer on pentacam, you realize there is a posterior elevation and the thinnest point is somewhere else, not in the center. Such kind of cases are subtle case of topography and we would want to rule them out. Sometimes the pattern may not be of an ectasia. The pattern here, what we are seeing, is pattern of with the rule astigmatism. All patient has is low pachymetry. So does it mean that it's ectasia? Well, at this point of time, I won't call it ectatic, but certainly on a bad D display, it shows that it's not a normal cornea. On top of that, when you do corneal biometrics testing, we realize that it's weaker cornea, and such cornea are not suitable for further weakening by any of the weakening procedure, let alone just LASIK. In fact, this patient needed collagen cross-linking, and along with collagen cross-linking, we could combine a small amount of refractive correction by doing a partial PRK, where we could reduce some amount of cylindrical power there. All these things, what we want to avoid is post-LASIK ectasia. So finally, what is our goal is not to have a post-LASIK ectasia, by which we mean that the corneal posterior surface starts showing changes, and which ultimately ends up in asymmetric astigmatism, leading to an abnormal vision. Well, we know that prevention is always better than cure, and we always look for the pointers which can tell us that which are the cases which can ultimately end up in ectasia. And there are a few criteria which have been given. Your residual bed, which was described as more than 250 micron. We nowadays aim for more than 300 micron. But trust me, it's not just residual bed. which is as bad. In fact, we all are not very proud, but 20 years back we would have done surgeries for -15, -12, and which we would not do it now. But are all of them ectatic now? No. The incidence of post-LASIK ectasia is very low. So it's not that every case which has low residual bed will become ectatic, but certainly that's one of the important factor which can be possibly responsible for post-LASIK ectasia. We have come out with something we call AccuSimX, and basically this is a model which we have generated using something called finite element modeling and using AI along with that. So what we do is we take the data of the patient, which includes the clinical data, and then we take data from Pentagon, which is shape data. We take data from Corvis, which is the corneal biomechanics data. Together we generate a mathematical model we call finite element model, and that element model we actually subject it to the digital surgery. So we can do surgery which is like say PRK, LASIK, SMILE, and then we can generate a model which tells us that what is the predicted biomechanical strength of these cornea. When you run through the entire model, which can take few hours, and then it shows us, is this something which is predicted to be abnormal, or like is it safe enough to go ahead with the surgery? Does it mean that we can 100% avoid ectasia? No, it's not just that, because ectasia is not related to the surgery only. Ectasia is not related to pre-op condition only. If patient has habit of direct and indirect eye rubbing, which to me is something highly underestimated. Direct eye rubbing we possibly talk about, but we forget about indirect eye rubbing, which is sleeping position. With somebody sleeping with their hand pressing their eyes, prone position with pillow pressing their eyes, is prone to ectasia, whether it's keratoconus or post-LASIK ectasia. So we do not need to take blame for every possible thing. Next thing is low corneal thickness. As we spoke about residual bed, same time the low corneal thickness is equally a deterrent for us to not jump over and do the procedure. If you see the pentacam here, rest everything seems fine, no ectasia, nothing at this point of time. All we have is low pachymetry, 465 and 467. Can we go ahead? Well, if it looks fine, everything fine, we may be fine. But just adding one factor here, family history of keratoconus, I would never touch these kind of eyes. Now, there are enough report which shows us low corneal thickness has been one of the important factor for the prediction of ectasia. But same time, we also should know that there are other factors like something like percentage tissue altered, which is very simple. Anything which is more than 40 is something which has been significantly affecting the possibility of post-LASIK ectasia. Having said that, there are articles which showed that LASIK done in low corneal thickness as low as 470 micron or PRK done in as low as 450 micron has not become ectatic. Now, does it mean we can just go ahead and do it? Interestingly, I would say no. Thankfully, Gaurav and Rajesh and all friends reported this article in IGO, and where they reported that lower cutoff limit for us is 470 micron. If we want to do a PRK extra, 450 micron. Now, all you have to remember is, in your case, do you think that you are safe enough to do surgery? And tomorrow, if you are brought to the court, you need to quote something. Possibly this article is something which we can quote that, you know what, it's been reported in the literature. So you go too much off the practice or off the general practice, you are possibly dealing with the lawsuit which can come against you. So be very sure whenever you want to touch eyes which are not within the normal range. Second is the cataract or the lenticular aberrations which we have. Now, sometimes young patient comes to you, you are fine, but sometimes when you are reaching that presbyopia, they may have an early lenticular changes, and which can be easily nowadays seen with your eye trace, where your dysfunctional lens index DLI has reduced, and such patients are not the candidate for laser refractive surgery, but they are candidate for early cataract surgery. One such case, young lady with a significant amount of high compound myopic astigmatism. But the interesting part here, if you see, the cylindrical power what you have on cornea is exactly opposite to cylindrical power on subjective acceptance. It's very weird, right? Corneal astigmatism amount is also very different. So axis is different, the astigmatism level is different, which should make us a little bit aware that, you know what, this is not normal. When we did eye trace, we see significant amount of internal aberration. That means the aberration is coming from beyond the anterior surface of the cornea. And here, in this case, the dysfunction lens index DLI was absolutely abnormal. What we were dealing with here, well, it was clear lens, but they were displaced lens. We were dealing with Marfan syndrome. So sometime in early Marfan syndrome, if you see Marfan features, and many of them can have myopia also, please be aware that you might want to rule out early displacement of the lens. Next, very large scotopupil diameter. Though it's not very common in Indian population, we are blessed with smaller diameter, but sometimes we do come across people where they can have significant amount of large scotopupil. These patients are more prone to glare and not night driving issues. Just be aware. Sometimes it's okay to say no to somebody rather than doing a surgery later on suffering, you as well as a patient. Pre-existing glaucoma is certainly something which would not be a great idea to do a refractive surgery. The reason is that one, you'll not be able to monitor the glaucoma properly because your intraocular pressure measurement itself may not be the best. It reduces the contrast as if the glaucoma person with the field effect would have reduced contrast. I would never want to do a refractive surgery there. Corneal dystrophy, the obvious dystrophies like lattice granular dystrophy, they can reduce the vision, they can lead to haze. Fuchs endothelial dystrophy would alter the corneal biomechanics, and of course you do not want to operate such kind of cornea. But sometimes it can be very subtle. As you can see from here, a young patient who had myopia, rest everything was fine, best corrected vision was actually fine. But clinically, if you see, there was a mild haze on the near posterior surface. This was a pre-descemetic dystrophy. There is a dystrophy called pre-descemetic dystrophy. Interestingly, when you do an eye trace, here uncorrected eye trace, so when you do no vision correction, this is how the total aberration would be, which is bad, of course. Moment you do something where you put total aberrations are eliminated with the eye trace, you still see aberration which is going to be present. Now this is what patient is going to suffer after your surgery is done. So though it may be very subtle change which are seen on the cornea, but it can affect quality of vision and ultimately it can affect the patient. So we all know that there are absolute contraindications for laser vision correction where we do not go ahead and offer them surgery. There are some relative contraindications like very bad dry and those kind of things. Ultimately, it's your decision. What you want to do with patient solely depends upon how you're going to take care of this patient in future. It's okay to say no to patient rather than suffering yourself and patient in future. Thank you very much, and I'm pleased to be with you all here, and happy to see you all again in future. Thank you.